I'm Melissa Talamantes. I'm a gerontologist and assistant professor at UT Health Science Center in San Antonio in the Department of Family Practice. And today I'm going to be talking to you about psychosocial issues in aging. And I kind of would like to get a sense of who's in the audience. And so first of all, here in San Antonio, can we just briefly show of hands of physicians in the audience? 3 nurses, social workers, case managers. What is? Okay, nurse. Okay, thank you. Can we go to the different sites and Laredo? What, am I looking? Have to look at this camera, right? Okay. Laredo. Can you hear me? Eagle Pass. Maybe they're not back from their break. Eagle Pass. Okay. Edinburgh.
There's nobody here in Edinburgh.
Nobody in Edinburgh, okay. Who else? Waco? Corpus? Kerrville isn't on, yeah.
Kerrville is online.
Oh, Kerrville, you're on. Great.
Yes, we're here.
Oh, wonderful. I can't see Kerrville.
Well,
They just talked.
yeah.
How many there are at Kerrville, and can you just give me a sense of what your background is?
There's 2 of us, and we're nurses, master's prepared, and advanced practice clinical nurse.
Oh, good. There you are. Yay. Okay. And what setting do you work at? The VA? Is that, or?
Yes, we're in the VA.
You're at the VA. Okay. Great. Okay. Who else? Edinburgh? Laredo? Okay. Is that it? In terms of sites? Corpus? Okay, so we don't have anybody at Corpus, nor at Eagle Pass, nor at Laredo. So I'm talking to Kerrville and San Antonio. Okay, that makes me feel a lot better to at least have a sense of who's in the audience. Okay, we'll get started, and I'm going to make this a little bit more informal since it is a small group. And first of all, I would like to start by telling you a story. There's a 75-year-old woman who goes to her physician to get a checkup, a comprehensive exam. And the doctor examines her, and he doesn't find anything wrong with her. And he says, well, what are your symptoms? And she says, well, recently I've been having a loss of sexual desire. And the physician asked her, when did this start? And she said, last night and then again this morning. So, get it? I mean, in other words, that's one thing is that what we find a lot when we talk about psychosocial issues of aging is a lot of stereotypes with older people that they have a loss of their sexual desire, right when they turn 65, and that's something that we see in terms of training with residents and medical students who I work with most of the time. You find that very often is that's one area that they don't want to address with their patients. What I would like to talk about today, and this is the first time I'm using the PowerPoint in this type of setting, I'm going to briefly present some demographic trends. We'll explore psychosocial, social, environmental, cultural, spiritual, and end-of-life issues which affect older adults. Talk about challenges and coping strategies with older adults. I would like to discuss strengths and needs of various elder groups. Can they see that on the screen? Kerrville, can you see the screen?
Off and on.
Okay.
Yeah.
Can you see
Yeah,
it?
we can see
Okay.
it.
Can you please, if you can't see something or you can't hear me or whatever, please let me know because we want to make sure that you're getting everything. Okay?
Yes, we will.
Thank
We
you. And also, if you have any questions in Kerrville and also here, please feel free to stop me, okay? Then I would like to discuss resources and interventions. My background is in community-based resources, outreach to primarily Mexican American and Hispanic elders in the Southwest. And I know that some of you work in the VA setting, in institutions or in hospital settings, and so a lot of the issues will apply for these settings, but when we talk about community-based resources, then they may not apply in that particular case. Let me go over some demographic trends, and again, this is real brief because I don't want to just bombard you with statistics, and you probably know a lot of this information. But in 1992, there were 32 million people over the age of 65. And by 2030, 20% of all adults will be 65. Right now, it's about 12.5%. 85 plus, as Dr. McCarter mentioned, is the fastest growing population, and it's going to increase by 7-fold by the year 2030. The numbers of older adults from various ethnic, racial groups are going to increase significantly in the year 2030. And I have a chart actually that I need to show on this screen. I'm sorry, I forgot I had that. I'll keep you working here. Okay. I'm going to go back to that one, so just let me know when you... Okay, in 1990, there were 3.7 million elder adults who were identified as living below the poverty level. Okay, and so for an individual, the poverty level was 6,268, and for two persons, it was 7,905. If you look at economic differences with ethnic older persons and also different gender differences, there are substantial economic differences. With men, Euro-American men, the median income is $14,839, women $8,463. That's a real large disparity. You look at Hispanic men, $9,546, and then compared to women, $5,373. Can you imagine living off of $5,373 annually? African American men had a little lower income than the Hispanic men at $7,450, and then the women were at $5,617. Okay, that's all the statistics I'm going to give you, but I would like to start talking to you about two different theories of aging that have been around a long time. The first one is disengagement theory, and that's a theory that came about which talks about older people in society withdrawing from each other, and that's supposed to lead to psychological well-being of older person. And you hear this a lot when people become depressed, that they disengage from their family members, from their friends, from society in general. The next theory, activity theory, is where people are involved in a variety of roles and activities, and this is the way that older people should approach life. Dr. Karp, who was a research investigator in Texas, talked about how older people could go back to disengagement theory when they were in had a chronic illness, or were having depression or some sort of psychological or psychiatric problem, and this would come about, but they could go back to the activity theory and function well. When we talk about social support issues, this, and Dr. McCarter said this, and I heard him when I was coming in, it's really important to, okay, it goes the other way. It's really important that older people have support systems, and whether it's family, friends, or other informal support systems, this is very crucial for the well-being of older adults. Formal service networks are also very important for people who are living in the community and are homebound and who don't have family support. Community-based resources are very important, and we'll talk about that in a minute. Okay. We talk about environmental issues, and one of the things, there's two things that I'd like to discuss when we talk about environmental. One is personal losses and gains and social forces that affect older people that are in their environment. And the other is the housing. Let me first talk about personal losses and gains, where you have the death of a spouse, the death of other family members, friends, also gaining grandchildren, a gaining of a brother, a son-in-law, a daughter-in-law. Social forces can include status changes, prestige changes in social groups other than family. It can include when someone retires and all of a sudden they're no longer the CEO of a large corporation, but now they're a retired person, and so that's a status change. That can also cause a lot of stressors. Socioeconomic problems are also really important to consider. I showed to you the income situation, which is I think something really common when people retire, is that if they have not saved or they don't have a lot of stocks and money hidden away, they may be only used to having Social Security as their primary income. And this happens a lot with older adults from different ethnic minority groups. They rely on Social Security as their primary income. When we look at problems with other losses, there's the sense of uselessness from a lot of people who've retired who never had any hobbies or anything, and all of a sudden they're at home with their spouse and they don't have anything to do but stay there, and they feel very useless. And so this is a big problem. There's also intrinsic factors that affect the psychology of aging, and those include personality. And a lot of times I hear from people who aren't aware about these issues talk about how, well, you know how older people are when they get old, you know how they act, or older people are all stubborn. I mean, you hear people make comments about that. Well, probably the reality is that person was probably stubborn when they were younger, and now they're just older and stubborn. But we're faced with so many negative stereotypes and myths about older people that we have an uphill battle, I think. And hopefully this will continue to change, especially with the baby boom population retiring. Stereotypes will not be as negative. And also I think as our media portrays more positive images of older adults, I think this is really important. You do see older couples in intimate situations more and more on TV. In magazines, you see older couples that are healthy and well, and so there are more positive images of older adults. Physical diseases of any organ system, again, can cause a lot of psychosocial concerns with older adults. When we talk about environment and housing, when we go out and make home visits in the community, this is a really important area to provide training for our family practice residents and medical students. Because as they become physicians in private practice, often they will prescribe to their patients, you need to exercise, you need to do this, you need to do that. But perhaps in their own home environment, they don't have the resources. And we've made home visits where the neighborhoods, there's a lot of crime, or there's no sidewalks, which is something real common in San Antonio, and so they just can't, freely walk around the neighborhood. And so this is something that occurs all the time, and bringing family practice physicians and other physicians in training to see home environments and to assess the older person's environment in their home is very important. What are they eating? How is the lighting? How is the layout? Are there throw rugs where they can easily slip and have a fall? their bedroom, do they have anything that could be dangerous, candles. Something that we see real often here in San Antonio with some Mexican American older people is that they use a lot of candles, they use a lot of velas, and then that could be dangerous if someone, an older person, had a dementia and would forget to turn the candle off. It could start a fire. And so there's a lot of things that need to be considered when you talk about housing issues. How does culture affect psychosocial processes? The impact of ethnicity. And again, there's still very little research on this area in terms of how ethnicity and race impacts psychosocial issues. We do know that in certain ethnic groups, family support systems are very strong, and they make up primary caregivers with these older adults. That older adults in different ethnic minority communities do not utilize resources in the communities readily because their families are working with them and helping them in their homes. We also have inter- and intra-group differences within ethnic groups. And again, in the Hispanic community, there are many different subgroups. The Puerto Ricanos, the Mexican Americans, Cuban Americans, South Americans, Central Americans have different cultural holidays, different foods. There's also differences in language, in certain words. And so we have to be really consider that when we work with that particular population. I mentioned before that the nuclear family and extended family are very important with certain ethnic groups, and we find that very common with the African American and Mexican American communities, that they do rely on their families as primary caregivers. What does the role of traditional beliefs play in terms of healing? And this is something, again, we talk about alternative therapies and traditional therapies in medicine, and that's, again, something there's a lot more research going on in that area. But what's commonly used with Mexican American elderly is teas and herbs for healing. And we see that very often, and probably the physicians here could talk about that at length with patients when you talk with them about what other things are they taking to help with their stomach ache or their flu or their cold. They may mention that to you, that they take certain herbs and teas. Finally, spirituality is a very important part of psychosocial issues in aging, and faith is very important in terms of the healing process for a lot of these older adults. And I just want to share with you briefly this experience recently that I had with the research project I'm doing. I was interviewing a 106-year-old nun here in San Antonio she's alert, she's still can ambulate, she uses a walker, she's very bright, very sharp. And I was interviewing her about, can you put the camera back on me? Can you? Sorry, I feel like I was interviewing her about her spiritual growth and what exactly, how is she dealing with that? How is she working on spiritual issues in her life? And is she now has resigned herself? Is she comfortable now with her spirituality? And as she's 106 years old, and she said to me, I'm still working on it, and that's something that I will continue to work on for the rest of my life, is the spiritual issues in my life. And this is something that I think is more and more important to older adults, and often is not addressed with physicians, and the power of prayer and healing. And something that needs to be considered, because again, they rely on, many times they say it's in God's hands, and you may hear that a lot from your patients, that I'm going to leave it in God's hands and in your hands. And is that something that comes up with you all in terms of the patient talking about God and healing? And
Yep.
do you face that a lot? Okay. So I think what we try to do now in the training of our residents and medical students is bring this up and talk with them about questions that they can ask their patient when they're doing the history. What are some of the things that are important to them, and what are their values? And these are some of the things that make up the spiritual issues. Excuse me for the going back and forth, but it's new with trying to do this. And I guess when you think about your own aging process, is this something that's important that you think about a lot, is the spiritual issues of your life. And yeah, I think this also is a developmental thing and a growth thing that happens, is that as we get older, this seems to be a more important area for us. End-of-life issues is another very important area that I wanted to touch upon. And there's been a lot of studies on advanced healthcare directives, and I know that those of you who work in hospital settings have had training in this, because it's a law that you have to ask your patients if they have an advanced healthcare directive. Well, we did a study here in San Antonio, and we interviewed Mexican-American elderly about their knowledge and use of advanced healthcare directives. And we wanted to find out what they thought about it, if they had an advanced healthcare directive. And I'm not going to define that, because the next speaker is going to go into detail about all these different advanced healthcare directives and in her ethical discussion. But one of the things that came out was that 90% of the sample said that they expected their physician to bring up to them the issue of end-of-life and advanced healthcare directives, and that they were comfortable with their physician bringing that up. And only 10% felt that they were not comfortable discussing the issue. But 90%, that was really significant. And when we look at all the other studies on advanced healthcare directives, majority of older people over 65 want their doctor to talk to them about advanced healthcare directives and about end-of-life issues. They're comfortable talking about that. But what happens is that we're not training physicians to do that, or to feel comfortable doing that. And so, again, this is something that we're working on in the department, is providing training to the residents and medical students about how to ask these questions, how to bring it up so that it's something natural and it's not something that, is uncomfortable to deal with. And part of it is being comfortable with your own end of life and thinking about it. And just a show of hands, does everyone have an advanced healthcare directive in the room? Most of, majority. And in Kerrville, the two people in Kerrville, can you hear me? Do you all have an advanced healthcare directive? Right.
Yes.
Okay, great. And the majority, when I go out into the community to talk about advanced healthcare directives, the reality is people don't have one. One of the problems is when they passed the law, the Patient Self-Determination Act, they really didn't have any provisions for how to provide the training about it. And so what happens is that they wait to, the community really waits till they are hospitalized, then are given all these forms to fill out. Do you want this, do you want that, DNR, and this, and it's, can you imagine, the stress that people are under. So what we try to do when we go out in the community is to teach people about advanced healthcare directives so that they can start working on it and take it to their doctor and say, I have a question about this, or this is my advanced healthcare directive, or, this is a real complex issue. And so what I recommend is using values histories as a supplement. And I noticed on the syllabus of the next speaker, they are not talking about, I don't think she's going to talk about values history, but basically this is a tool that can be used as a supplement to an advanced healthcare directive. And if anyone's interested in having a copy or seeing a copy, I would be glad to share that with you. And basically it talks about one's values, how they feel about certain things, what they have enjoyed in life, what kinds of things they want, and it's more detail. It's not just, I want to be resuscitated, I want to do this, I want that. It's more, it provides a better overview of someone's real feelings about their end of life. And I don't know, has anyone been exposed in the group to values histories in this group? Okay. It's something that can be used to help open up the conversation with your patients. And you give it to them and say, take this home and read it, look it over, and then the next time we meet, we can talk about it if you have any questions. And then the physician or nurse or whoever in the community agency keeps that values history in their chart and can refer to it in the future if a situation would come up. So I think this is really important to consider when you're working with your patients, to maybe provide them with the values history that can be supplemented. I'd like to talk about different characteristics that the literature shows and also that I see anecdotally with the older people that I've worked with. And these are the areas on desire to leave a legacy. And again, older people really do want to leave things with their children or grandchildren, whether, not only just material things, but also just their experiences and life experiences. That's something very important. Legacy provides a sense of continuity, giving the older person a feeling of being able to participate even after death. And then the elder function is the propensity for older people to share knowledge and experiences with others. And this is something really important, I think, that we as providers need to be aware of, that despite someone's frailty and inability to be active in a community, they still can participate in the community in a teaching role. And I'd like to share with you an example that I think is really a good example. We have first-year medical students that we send to elder professors in the community. These are older people over 60 who have agreed to be an elder professor. The medical students are required to make 6 home visits per year, and every time they make a home visit, they sit down and there's like a plan. This time we're going to talk about different screening tools. There's a plan for them to be able to talk about a certain topic of learning, but really the goal of that relationship is to try to have them meet older people that are still active in the community to develop more positive images of aging. So again, these older people who are elder professors are very active, and many of them travel, or others who aren't active still volunteer in some capacity in their community. And so the medical students have been really impressed by this. They say, why, my image of older people has always been maybe, they live all in a nursing home, and they don't realize that the majority of people over 65 live in the community, whereas a less percentage live in a nursing home setting. The sense of life cycle or attachment to familiar objects. Again, and those of you who work in a assisted living facility, skilled living facility, or in a hospital, you know that familiar objects are important. Pictures, photos, scrapbooks, just things that remind them of their life, that they can reminisce and have life review about, are really important. The sense of life cycle is, older people are the only ones who have a true historical perspective. And now that we're seeing centenarians talk about different decades and what they remember, it's fascinating to hear. And so it's really something that's important that they can pass on to others. Creativity and curiosity. This is something, again, that's really vital with older adults. Many of them go back to school, get second degrees. I know several of my friends are in their 60s and are going back to get their doctorates or going back for another career. This is very common. You have lifelong learning programs in community colleges and universities. It's something very, very common, very important. Okay. In terms of strengths, we see that whether someone is frail or active, there are commonalities. And those commonalities is they have the wisdom, the experience, and the time. And so what's important to them is to feel useful. And this is something that, those of you who work in nursing home settings, being involved in some kind of activity is very important to older people, as is in the community. Many people who have retired and who never had hobbies, once they're plugged into some kind of resource, this is really important for them to be able to feel useful and needed again. Again, they participate more in the political process, they volunteer more, they make better workers, and they have greater wisdom. You see so many large corporations now hiring older adults. And I see a lot of people at HEB, older adults, and at Walmart, and also people that are on advisory capacities of large corporations. I mentioned that people have a need, and this is a human need, it's not just a need of older adults, but to to be purposeful, to feel needed, to have a listening ear, to teach and to grow, because you never stop growing. I mentioned that community-based resources that are available that I think are really important, and for those of you who work in a clinic setting, this would be really important for you to be aware of. There are case management programs that can link older people and their family caregivers to these resources, because I know, in your busy practices, you're not going to have time to be making calls, and if you don't have the social workers to do it, because I know some settings have cut back, and there's one of the most important part of the team is not there anymore in the social worker, but there are many programs available in the community that people can benefit from, and this is a way that people can continue living in their own homes if they can utilize these resources in the community. We provide training to our residents and medical students on these resources. They have to make visits with many of these agencies and also help older people link up with these resources, which often can be very frustrating. If an older person themselves is calling a particular agency and they get the voice machine, and I know all of you probably have experienced that before, press 1 if you want to talk to so-and-so, press 2. If you want Spanish, press 3, press 4, and by that time, someone who maybe just Spanish speaking has already hung up, or someone who has a hearing loss will hang up. I mean, trying to maneuver the system is very, very frustrating. It's frustrating for a professional who has a lot of experience doing it. And can you imagine for family caregivers and for the older person themselves, if they have a disability, it's very frustrating. But try to link up with the case management program in your community to get these resources for people. In terms of hospital interventions, this is a really good place to detect older persons that are at greatest risk. When they have a hip fracture, after rehab, what's going to happen? Have families talked about the home environment to adapt it again to prevent falls? Again, all these things I think need to be discussed in the hospital, at least planned for with families. And so I think social workers should be prepared to integrate with the community-based organizations to talk about this. Again, comprehensive assessment with a multidisciplinary team is very important, and you're going to be getting a session later on all of this, so I'm not going into that. Okay. Does anyone have any questions? Okay. Kerrville, are you still with me? Kerrville?
Yes, we are.
Can you hear? Okay. Do you have any questions?
No.
Okay. I think this is a real tired, laid-back. Did you have a question?
I have a comment. I think that a lot of times providers do not address sexuality or spirituality, cultural aspects of aging in their assessments or whatever, simply because they don't have a sense of feel of what it really means to the individual. And this slide that you had on legacy, elder function, attachment to familiar objects, and so forth, I think embedded in that are spiritual aspects of the individual as well as the cultural aspects and the self-identity that would also encompass the sexuality.
Kerrville, did you hear that comment?
No, we have difficulty hearing the question.
Oh, it wasn't a question. It was just
It was a comment.
And Pat's very soft-spoken.
Do they know you?
Yes.
Why don't you repeat it?
Yes, we know her.
Carrie, what I was saying is that I think sometimes we don't address as providers sexuality, spirituality, and cultural differences with outside the parameters of what is considered ethnic groups. And therefore the culture is not assessed well. And I thought that slide on legacy, elder function, attachment to familiar objects, and so forth, embedded in that are some of those issues, and they might make a better tool of assessment than just talking about sexuality or whatever, because we have our own definitions of those things, and generally is not what's meaningful to the patient.
Yeah, that's a really good point, and I think that that's where you can begin, you know, when you are assessing in that type of setting, is talking about, well, what does this mean? You know, tell me about your husband in this picture, and what was your life like, and those kinds of things, and reminiscence and life review, I think, are really important tools for older adults. Can you dim the lights again? This is the last thing. This is my conclusion. And those of us who are in gerontologists, we focus on we like to focus on more of the touchy-feely kinds of things, and probably, you know, I don't know if you'll be turned off by this, but I have a poem that I'm going to end with, and some slides of older adults. Can you, do I need to close down here? And I appreciate your patience with the technological aspects of this. Can I put this on the screen, on this, as I'm reading it? Again, I think as providers, we just look at the person as, when we work with older people, we just think of them as who they are at the moment, but often we don't imagine that, you know, they've lived a life, and they have history that is really important to them, and they want to share that, and I think that's really important. Can we put this on the...
Can you turn the lights on, please?
Oh. I'll just do it anyway. I'll start. Look me in the eyes and listen. Don't talk to the top of my head. Don't patronize or infantilize. Hear my words, for they are true. My feelings strong. My dreams and hopes are real. I am not arthritis, although sometimes I have some pain. The medicine you prescribe relieves the stiffness that remains. I am not dementia, although sometimes I forget. I have much going on in my life and often don't pay attention to what I have said. I am not depression, although sometimes I feel sad. Too many life changes can go to my head. I am older and wiser and know who I am. All the years I have lived have helped me learn and grow. My peers will agree we are very different in so many ways, but we are the same in this way. Dignity and respect are your best bets. Hear my plea, accept me for who I am and not for who you want me to be. And this is my grandmother, and she was 97 when she died 4 years ago. So, thank you very much. And thank you, Kerrville. We're going to take a break before the next speaker comes on, and how long is the break? 10 minutes? Oh, okay, but is the speaker here? Oh, you are, okay, great.